month for 4 months, held off-site. And we got about the top 40 administrators to come through. So I would present the concepts, would have this big discussion about whether it was legitimate, how it would work inside Intermountain, what resources it would take, what barriers we should expect, what results we should demand. Funny thing is with that one, well, I didn't require people to do projects. It would have been hard to manage. And we came to no formal conclusions at all, but it's fair to say we walked out of there with a shared vision that drove change at a massive rate from that point forward. And essentially all of those administrators came back and took this course, the full ATP. So Bill Nelson, who is then our Executive Vice President and later became our CEO, is our CEO today. Bill's a graduate of the course. Again, his project that he did while in the course, he was CEO of the health plan at the time. He shortened the length of time it took to pay a physician claim on the health plan from about 40 days down to 4 days without adding any resources. And I think that's where Bill kind of became convinced of this stuff, that it actually worked, based upon that experience. Well, fast forward with me now. The year was 1995. Bill was our Executive Vice President, and he came back to me. He asked for a summary of our clinical improvement, right? Well, wait a minute. This was Bill asking. He was our Executive Vice President, an accountant by training, and our Chief Financial Officer, too. And so when Bill was asking, I knew he meant financial outcomes, by and large. So I threw together a summary of financial impact of clinical improvement inside Intermountain. And what I ended up doing was just looking for projects. At the time, I could identify about 65 clinical projects that had worked, just in the Intermountain side. Lots more non-clinical ones, but 65 clinical ones. I don't know, it was about 1 in 4 of the projects we were getting out of the class, but you have to understand the class was producing a lot of projects. And even the ones that didn't kind of go golden to hit this list, we had some very strong ones back behind. They just weren't as fast to bear massive results, right? Well, 65, Bill wanting financial outcomes, I figured. So I just listed them out. Now, actually, at a process level, that's what I really mean 65 protocols. At a project level, the list was shorter. So this is actually about 30 of them. The reason is for example, Terry Clemmer, working in our level 1 trauma unit, shock trauma respiratory ICU, that was actually 12 protocols. Mike Dean's work with his nursing team up at the pediatric ICU at Primary Children's was a minimum of 8. It was more like 10, actually, protocols, but there were only 8 I was counting at the time. So this is a list of about the first half of them, and I've listed them in order of financial impact. On many of these, we were tracking finance pretty accurately. On all of them, we had some estimate. Now, guys, there's a message in this. When you're doing your own projects at home, don't forget to track cost outcomes. It's going to be essential to convince your administrative colleagues that this is a legitimate business concern. So, Chris, even if you're dealing with a bunch of anesthesiologists, in some sense, they're businessmen too, aren't they? Running the practice, and they'll want to see the cost data, not just the clinical data, even though the emphasis may be different, if you see what I mean. Or that would be true for any clinician in the room who leads a group. Sorry for picking on you, Chris. It's just that I know you, so I can use you as an example, you see. Well, to finish it out, it would take 4 additional slides to list about 35 additional projects. The total cost impact on the system was about $30 million a year from these things. And so it was quite easy, actually, to justify the whole effort, not just the course, but my whole department, on the basis of that. The single biggest cost associated with running the course is your time away from work. It's far more than your tuition. It's far more than the food or my time to teach or the paper or anything else. It's time away from work, but we were running those numbers, and we knew what they were, and we're being pretty honest about it. And still, from an Intermountain perspective, this was one heck of a return on investment. A lot of secondaries coming out of it, too, in terms of culture change and leadership capabilities, stuff like that. Well, looked pretty darn impressive. Nobody was saying we ought to back off, but you might be surprised to know at that point in time, Bill Nelson was kind of the bane of my existence. my problem was I worked in the same building with him. And it means you bumped into him regularly, would be in meetings together, right? Bump into him to the hallways. I mean, every time I saw him, I couldn't even bump into him in the men's room. That he wouldn't gig me yet again on my science projects. He called these science projects. And he didn't mean it in a nice way. All right? Oh, the reason he called them science projects, you see, with 3 exceptions, they all happened in a single location. 3 of them we managed to spread across the system. For example, fast-track extubation, 4 big thoracic intensive care units, all 4 of them used it. Community-acquired pneumonia, Kim Bateman spread it across the entire system. You'll have a chance to meet Kim, the guy who led that project, after lunch today. He's going to come and share his project with you as a storyboard, as a model for your own project, and also just so you can get the details of how one of these really works, right? Well, yeah, 62 of them happened just in the practice of whoever was sitting where you're sitting out in the course. And I'd done, at Bill's behest, a little what-if analysis. What if we'd been able to move the other 62 to every care delivery location that saw similar patients within our system? What impact would have that had, you see, if we'd been able to deploy them broadly? Hey, this was 2% of cost of clinical operations at the time, roughly. But it turns out if we'd just been able to deploy these 65, I mean, they weren't even picked strategically. This was just what people wanted to work on in their own practice, which is not a bad way to start, but you could be more focused, you know. It wasn't 2%, it was 6 to 10% if we'd been able to deploy just across that set. It wasn't $30 million a year, it was somewhere between $100 and $150 million a year in potential cost savings. All right? And probably bigger if you got a strong strategic focus. Now, in fairness, guys, our system volumes at the time, when you realize that as much as 50% of all healthcare delivery is potentially waste, you know, wringing out 10, 15% is a good start at best. You know, so it's not unreasonable. Well, yeah, the numbers were fairly convincing. Bill knew about them. And every time he said science project, his actual purpose was to remind me of a goal that he had for me and mine, for us here. He wanted us to figure out some way of deploying this out broadly. So it wasn't on a project basis. All right? That was his goal. And that was his way of reminding me of the goal every time he saw me. You know, he'd tease me about my science projects and what am I doing to make them beyond just another science project. This is a legitimate tease, by the way, because as a kind of a guy with a heavy research background, my specialty is one-off projects and then go on to the next one. And somebody else deal with the reality of it. You see? Yes. This was from 1986 to 1995. So it was 9 years. All right? For a big system, fairly heavily focused on it. Yes. Yeah, did the culture change start in 91 with the mandate? We actually started the full ATP in 91. We'd been running a version of the course at that point since 1987. And that's when we went to the full big clinical course. And see, Dr. Deming used to, I talked to him about this, and he had this saying. He said, if you want to change the culture of an organization, well, first of all, he said it's cultural. You got to get people to see life in a different way, see their work life in a different way. And he said, in changing a culture, he said, you don't have to get everybody. He said, you just need the square root of n, was his rule. And by square root of n, he said, if there were n individuals in the group, if you got the square root of that, then you'd have changed the culture, and it will start to take on a life of its own and move itself ahead over time. All right? If he'd lived long enough to read Rogers' famous text, Diffusion of Innovation, he would have said early adopters, because that's clearly what he had in mind. Rogers had a more precise definition. But we were targeting lead clinicians, physicians and nurses, and then that was the context that led Scott Parker to say all senior administrative leaders. All right? And it's fair to say, yeah, that's what drove a massive culture change. So here's the point. It wasn't enough to just get the clinicians. You had to get the administrators too. And frankly, it wasn't enough just to get the administrators. You had to get the clinicians too. Because if we'd been missing either side, we would have really struggled to move it ahead. And it fundamentally changed the argument. We no longer argued about whether we ought to be doing this stuff. We instead argued about how we did it. Because there was we'd moved beyond it. Nobody even talked about it or thought about it. It was how do you do it, not whether you're going to do it. You see? And so there's a fundamental shift in there. Now, it's a funny thing. I'm a little off track here, but it's worth mentioning to a group like this. I've many times asked myself, sat and thought, is there another way to do it? And, I don't have any theory that says this is the only way to drive this kind of shift. The only other way I've really seen is a near-death experience, by the way, where a company has to change or die. But how do you drive that basic fundamental shift from Taylorism to process management? If it's not external market pressure, how do you drive it? Because it has to happen. And it's a little bit of an artificial place to put people's heads in. It's hard to maintain there, right? We tend to be naturally Taylorists at some level as human beings. And so this requires work to kind of hold yourself there. How do you get that? That's how we did it. And I haven't been able to think of another way that we could have. So there you go. Yeah. Yes, in several different ways. We're going to cover much more detail around strategic planning as we move ahead. So this is one part of all the strategy coming up, and then we're going to give you the tools of strategic planning. I think it's a session later this week around quality planning tools with Scott Lloyd and Christy North coming in to teach that. All right. Well, you get an idea of what's going on here. Well, as a result of this, we went out to build a strategic plan. Yolanda, just as you were asking about, I got a freebie, frankly. I got a true blessing. Probably the finest strategic planner I've ever met in my life is Dr. Dave Burton, Harvard-trained internist. And just to give you a feel for the guy, he was leading an emergency room group, independent, community-based group that covered 2 of our hospitals out in South Salt Lake. So practicing emergency physician who led those groups. As a practicing physician, he anticipated the role that insurance companies were going to come to have in the United States. This was back in the early 1980s. And put together a pro forma business plan and convinced the senior management of Intermountain, our board of trustees, to start our health plan. Dave was its CEO for its first 3 years of operations, did all of the planning, and actually ran it for its first 3 years when Bill Nelson took over for him. All right? So a little bit of an unusual physician. It's fair to say. And easily the finest strategic planner I've ever met. His mind just works that way. Well, Dave was the senior physician in all of Intermountain, sat on our management committee. When he was called by the LDS Church to serve as a mission president, that happens in this community, means that he dropped everything and on his own ticket went off to Germany to run an LDS mission with all those young missionaries out there, Gone for 3 years, came back at the end of 3 years. Now, it's not the only time it's happened to Intermountain or other organizations in this community. It happens with some regularity. And you try to support your people. It's fair to say, though, that he'd left a vacuum when he left, and we'd kind of filled the vacuum. So when he got back, he had a desk and he had a paycheck. He just didn't really have a job. Well, this was right when Bill was all over my case about getting something going to deploy, and suddenly I had the world's finest strategic planner kind of dropped in my lap. And so I went to Dave and said, hey, Dave, will you help me do this? He came through the course and used his project was actually the first outlines of a strategic plan for this, right? So what you're going to see is a partnership between me and Dave Burton is how this happened for us. Well, we got looking at it, and it turns out in the quality improvement literature, the circumstance we found ourselves in of not being able to deploy is pretty well described. A contemporary of Deming's, Dr. Joseph Duran, he died earlier this year in his 90s, great guy, founded the Duran Institute, great gift of speech. He could write and speak at a level much higher than what Deming could, all right, very good at it. Deming was kind of the theorist, and I guess that Duran was Aaron to Deming's Moses, if you're familiar with that story. Because he was such an eloquent presenter. Turns out that Duran had written about this at some length in the theory. He pointed out that a total quality approach requires 3 major sub-elements. The first, well, technically his book, Duran on Quality Control, is the name of the volume. It's the first one he published, but it's a management system based around quality principles. He said if you have that in place, your quality improvement activities, so this is Duran on quality improvement, your improvement activities will explode upward with this infrastructure to build it on, all right? And then thirdly, he talked about design principles, quality design principles, and published a series of volumes describing these three areas. Well, one of the main points in that, he said, look, if you don't have the infrastructure, you won't be able to deploy. So I mean this as a fairly pointed criticism of healthcare for the last 20 years that we've been working on improvement. We as a profession, as an industry, have focused pretty much exclusively here on improvement. And what we've got is a bunch of one-offs, a bunch of projects. But to move to quality as a core business strategy, quality is a way you do your business, right? Quality that deploys, you've got to build this infrastructure. I remember as we went through it together, Dave compared it to laying railroad tracks. He said, we're going to go out and we're going to lay some tracks. And he says, once we get our standard track laid, you'll be amazed at how much tonnage we can roll down that track. He says the trick is, he says that building track is a thankless task. You're consuming resources and people don't see much for it, right? And even after it's all up and running, they'll see the trains, they won't see the track, by and large. So a thankless task, and well, that's how I've spent the last 10 years of my life, is laying track. You know, and that's what it comes down to. So Duran described it nicely. In this strategic plan, Yolanda, we're going to be talking about laying the track, building the infrastructure, right? So that it's possible to deploy broadly. It has the feel of making quality your core business. All right? Well, actually, that was our first step as we started into this thing. We realized that we needed to have a conversation with the leadership of this system, both on the clinical and the administrative side. What we used was this principle right here. So this turns out to be largely a true principle. You manage what you measure. True principle for organizations, for sure. I realize there are many things in our lives that we need to manage that we don't directly measure, at least don't formally measure. I'd argue that we probably do measure them, assess them somehow. But within an organization, particularly your measurement system is your nervous system. It's how you hold people accountable. It's how you set and achieve goals on a broad scale. What we did was we played it backwards. We said we can tell what we're managing by looking at what we're measuring. All right? And so we just took a look at what we measured, what we set goals around. We looked at what the strongest committees on our Board of Trustees were. We talked to people about what they saw as really determining their ability to advance within Intermountain. And what we saw was 100 years of history. We talked about it last time. 1895, Johns Hopkins University Hospital, where they separated administration from clinical practice. Remember that? Well, over on the administrative side, these guys have been tasked with the financial stability of the institution, managing the facility, supplying the resources to the clinical practitioners, right? And that's what we found 100 years later. If you looked at least at Intermountain and saw what we really tracked, what we held people accountable to, I mean at a fundamental level, it's pretty much exclusively financial measures organized for facilities management, was our assessment of it. Now, there was a certain amount of tip of the hat to quality, but it was mostly Joint Commission requirements. These were external regulatory agency requirements. And it was very clearly done in order to meet those requirements so that we could practice, right? But it's fair to say it didn't get the same degree of attention, it didn't get the same degree of power. It's not the basis for which you'd get promoted within the company. I don't know, as you think about your systems, Susan in Ohio State, are you close enough to that system to see what the administration really uses to manage? Am I too far off? No? Yeah, I have a number of other systems. And well, let's do it the opposite way, though. Is anybody willing to make the argument that their organization primarily focuses on clinical quality measures as a means of promotion, as a means on the administrative side now for running their system? That they don't rely primarily on financial systems? See, I use this as a little litmus test myself when I go out and visit places, and you have to dig for it a little bit because there's an awful lot of surface words on top of it. But I'd have to say that's what I consistently find. And even here in Intermountain, this would have been in 95, that was clearly the case. I mean, even after we had this stuff up and running and it theoretically shifted our culture, I had Jim Reinertson, whom you will meet if you don't know him already, one of the best physician leaders I've ever met, I think. I had Jim come in and do an independent assessment for me. He interviewed all of the senior leaders in Intermountain. And what he came back and said is, despite all the superficial, lip service to clinical quality, he said the underlying core belief is that the way you get promoted in this corporation is being able to manage a budget. Right? So those of you who are Intermountain, am I being fair, Chris?
I think in today's healthcare environment, you have to be very careful about managing your finances because you're operating on such a small margin.
And if you no money, no mission, no margin, no mission, right?
Right, and I think from my perspective, at least the things that I've tried to be involved with, the people that are in higher leadership positions, I think they're pretty much on the same page with where the clinicians want to go.
Yeah.
There's a disconnect in middle management.
So, but, yeah.
Having their feet held to the fire or managing their budget.
So you have the higher leadership in the system that are pretty much same place as the clinicians. We understand this quality role, but it's the middle management layer, right, who's still really holding their feet to the fire on budget for those on the video. Yeah, I think you're absolutely right, Chris. And it's still largely true. Well, we used this, you see. We used it to set up a pretty good debate. We actually found a couple of our administrative colleagues who were willing to stand in front of the whole group and try to make the argument that the primary reason that Intermountain Healthcare existed was to manage facilities within which independent clinicians treated patients. So our real role, the way that we added value to our community as Intermountain, was facilities management. And boy, I mean, we really do behave that way. Watch our administrative staff get excited about building a new hospital, building a new facility. For example, that's where they like to spend their time and attention. And doesn't the clinical stuff really belong to the medical staff over there? Can I push that off on them? So again, am I being too pejorative? I think I'm describing essentially all healthcare delivery, not just in the United States, but in the world, by the way. Same thing in Canada, for darn sure. Same thing in Sweden. Same thing in Great Britain. You get this division between administration. In Sweden, they call it economy, by the way. It's their name for it, versus the clinical. And you get this, I don't know, it's not really conflicting goals, but divergent goals, at least. And it creates a certain amount of friction. Well, we got the debate going. You see, the trouble is that thing on the wall right there, it's our mission statement. It says that we exist to deliver care to patients. And we had to cast it as a stark contrast back and forth and work pretty hard to make it clear. A little caricaturization here to make clear the difference between facilities management as your primary mission versus patient care delivery as your primary mission. And it's a question of how do you add value to a community? Why do we exist? Now you need to know that in the end, of course, an awful lot of those guys were clinicians who had moved into senior leadership within our system. In the end, we concluded as a group that our core mission was care delivery. But I can't emphasize enough how important it was to make that fairly stark, as sharp a contrast as you can, so you can decide why you're really here. What our purpose is, what our aim is, what we're trying to optimize. You see, and having a very strong shared vision of it. That was the idea behind it. Yeah, we concluded that our business is clinical care delivery, not just facilities management. And of course, that then became that difference, that tension, became the energy for strategic change. And we concluded, well, we called it clinical integration. You see, we knew an awful lot about how to manage. We're really good at it, frankly. But it was the frank realization that our core business was clinical care delivery and we weren't managing it. We thought we really ought to manage care delivery. So we needed to shift our management paradigm from a financial administrative model. Not that we were going to abandon that. Don't get me wrong on that. It's very important. Still needed to do it competently and well. But we were going to now extend out and include a clinical process model and merge the old two halves of the system back together. The clinical leadership back with the administrative leadership. Right? And that in today's modern age, that's what it required. You could no longer treat them as if they were separate. That's what Deming really taught us. Well, that led us to a strategic plan, and it gave us a group of people who could hear the plan and respond to it intelligently. This is a basic outline of the strategic plan right here. So in 1996, we came up with a very strong shared vision, what our mission was, how we added value to the communities we served. The other thing we did that year is something absolutely essential. It's called a key process analysis. All right? And then each year, from that point on, we set major strategic goals at a Board of Trustees level for the senior management team. Dave and I were the leads on the goals, on achieving the goals, but this was a major, we had a larger strategic plan, of course, but this was just the big change goal, the major focus for this thing we called clinical integration. In 1997, it was to build an integrated management information system, or at least derive the methods by which you would do it and apply it to the first couple of processes. Just a point in passing, you have to understand Intermountain had tried to start clinical management twice and had it failed twice. Each time it failed, we lost about $5 to $10 million in sunk costs. Rough guess. Each time it failed, no guess at all, very definitely took out a senior vice president for medical affairs. Steve Lewis, followed by Kent Richards. Dave and I were now being assigned to try it for the third time. Third try. And we just thought it would be really smart to go back and look at the first two and see if we can figure out, from our viewpoint, why we thought they'd failed the first two times. And in taking a close look, what we discovered is in each of those circumstances, we'd found some very capable people who were willing to step up and try to lead. I mean, with Kent Richards' effort, we actually went to the Romney School of Business at Brigham Young University, and they designed an on-the-job MBA with a formal MBA degree at the end. And clinical leadership, we were getting trained as MBAs, so they'd have the business skills was the viewpoint. And frankly, it was a beautiful program. When I first read down through that proposal from the Romney School, it was just plain pretty, very competently done. And we trained a whole bunch of MBA physician nursing leaders, right? Still failed. Well, as Dave and I looked at it from the experience of having watched it all happen, we came to the conclusion that there was an, unconscious, unexamined assumption. The assumption was that we could use the same data that we used to manage the facilities to manage the clinical enterprise. All right? We were investing very heavily in data for the facilities. Well, essentially all cost data organized for facilities management. And we'd lived through a certain amount of this, right? So you take those financial data, this would have been with Kent Richards. We formatted it up, and, well, for example, we had these 7 big accounting categories for outpatient medicine, referral rates to specialists, hospitalization rates, pharmacy, imaging, so on down through this list, right? And so you found yourself going into a physician's office saying, doctor, we've been looking at your primary care internal medicine practice. Your prescription rates, your pharmacy costs are higher, statistically significantly higher than for similar practices in our system. And we think you need to do something about it. Your costs are too high. And he would look you back dead in the eye and say, well, which prescription should I change? And we couldn't tell. We just have to say your summary prescription costs are too high. Do something about it. This provoked a certain reaction among our physicians, a very predictable reaction. All right? Let's just say it didn't work. So when Dave and I realized this problem, we thought the first order of business was to say, is it possible to build the data systems necessary to manage clinical care delivery? I can tell you now, looking backwards, having done it, we were right. It turns out that we were missing a third to a half of the data we needed to manage clinically. That our financial systems just weren't picking it up at all. And that it was organized incorrectly. It wasn't organized for clinical decision making. It was organized for facilities management. You see? But that was the 1997 goal. And we managed to meet it. I'm going to show you the formal methods we came up with to do it. The following year, now that we had some actual data you could use to manage clinically, well, we faced a second major challenge in 1998. Now, in fairness, I was kind of our expert on information systems. Dave was our expert on management structures. Here was the problems with management structure, though I mentioned it to you earlier. Intermountain works with a total of about 4,000 physicians, but among them, about 1,600 or 1,700 account for about 95% of all of our inpatient and outpatient care delivery. That core group of physicians that are fairly tightly aligned to the system. Of those, say 1,700, 750 of them are employed in the Intermountain Medical Group or through hospital staff. The rest of them are independent community-based physicians or groups. All right? So it turns out we had about a 2-to-1 ratio at the time we were doing this, actually. It was about 500 of 1,500 that were employed. And as a result, we were never tempted to try to build a management structure to control physicians through employment. I'm going to come back and cover that later in the course. If we'd tried it, it almost certainly would have failed. Turns out there's a very good argument that you can't control physicians through an employment relationship. It's not effective. It has to do with educational levels, just in passing. Well, we were never tempted. So many of the people with whom we had to work were independent community-based physicians where we had no employment relationship, had no strong direct financial incentives either. We were forced to build the management structure around shared professional values, which turned out to work, I would say surprisingly well, but I wasn't surprised. I kind of expected it would, just knowing something about physicians and nurses. But it worked very well. But it was kind of a different sort of a management structure, right? Where you were going for shared values as opposed to control. It sounds more like learning versus Taylorism, top-down judgment, doesn't it? So it kind of fit, you see. We proved you could do it. And you need to know that at that point we started to show system-wide significant results in terms of clinical and cost outcomes around those two things right there. Now there's a third element. I've hinted at it a number of times, and we'll come back and cover it explicitly. It turns out we were showing massive improvements in cost structure. The trouble is that at least 3/4 of the time, as our cost of operations fell, our reimbursements were falling as much or more because of perverse payment mechanisms. So we were creating these windfall savings for purchasers, mostly for insurers and the federal government, right? And we had to come up with some way of getting some of the money back so that, well, we got some margin out of it. No margin, no mission. And so what I plan to do, we'll come back to this a little bit later on, but when we come back to it, what I plan to do is first take you through the key process analysis, show you what that looked like in outline form. Then I'm going to jump ahead and do management structure second. It's just easier. Then I want to come back and talk about management information systems. Oh, this will have a major direct application to your measurement for your projects, at a principal level at least, if not on the same order of scale. And then finally come back and talk about what you might do to make, well, quality a business plan to maintain your margins. All right? So that's what I thought I'd do with this thing. Now, in fairness, I know, yeah, we have people here from many different systems. I'm almost sure that your rollout would be different. But this is the one that I know really well. It's one of the few that actually exist. For a while, we were the only one that existed. And I wanted you to see at least one, just to see what it looked like when you started to build it in as a core business strategy. I think you'll find it quite interesting. Sound reasonable? So when we come back, that's where we'll kind of pick up the ball and start to move. So with that lengthy introduction, comments, questions, other issues? So time for lunch and consultations. We'll meet back at 1:30. Kim Bateman's going to present his project on community-acquired pneumonia just as a successful project and to show you some improvement experience. Once again, we do this every time, basically, is have some sort of a storyboard. Then we'll pick up again at 2:30 and just continue to move on down this list. All right, and I think the next day I'm actually back with you is Thursday afternoon, and we'll just, keep moving on it. All right? And if necessary, we'll push some of it back to the next session. That may be necessary. We'll see how it works out. Okay. Any last thoughts or comments? Food's on the back table. See you at 1:30 for Kim. Break. But it's only been an hour, so you'll probably enjoy that break a little later, I imagine. What did you think about Kim's presentation? You know, we do this to you each time, and the basic idea is to look at projects, how projects worked, at least partly to give you an idea of what your presentation might look like, and at the same time to show you something cool along the way. It sounded like pretty good discussion of the pragmatics. Any thoughts? Is that time well spent? Well, we were talking about how you might build a system that could deploy when we broke for lunch. And I'd laid out this basic structure. What I'd like to do now is just to step down through it. If I can stay on track, we'll see, go through key process analysis first, go through management structure, then shift over and talk about the information systems. And currently we're scheduled to come back on Thursday and talk about the financials associated with it, if that's possible. Just one quick question. We gave you a new DVD that's called Quality Controls Cost. John Foss, the guy on the camera in the back, created it. I think it's substantially higher production values than any of the others we've given you so far. Very nicely done. Is it possible that you'd have time to see that before Thursday? Run it on a computer or a DVD viewer at home? Is there anybody that would be a real challenge for? I think it runs, what does it run, John, about 30 or 40 minutes? 36 minutes about. Okay. If that'll be a challenge, let me know. But otherwise, if you could watch that in preparation, it'll really speed us up on that Thursday to have gone through that. So if I might impose for 40 minutes one of these evenings to go give that a look. It's actually got some awfully nice stuff in it. Well, I talked about how we got a shared vision running within our leadership team. The next thing was this key process analysis. Key process analysis is just based off the old Pareto principle. We talked about Vilfredo Pareto in the first session, that Italian economist who came up with the 80-20 rule. It's actually a key part, too, of the IOM Crossing the Quality Chasm report, the IOM's prescription for reform of the U.S. healthcare system, which would actually fit much of the world pretty well. Page 138. Maybe the core principle in the whole thing is the idea that you design your system for the usual. And that allows you to recognize and plan for the unusual. It frees resources for the special cases, you see. Same idea that we had in shared baselines. It's not that you eliminate expertise. It's not that you go to strict cookbook medicine. It's that you standardize so that you can kind of specialize, because that's a requirement in that particular structure. If you standardize, it frees resources so you can focus special attention on the outliers, right? It's actually a long tradition in the healing professions. You know the old saying, if you hear hoofbeats, think horses, not zebras. And it's the same idea. So the concept here is we're going to do things in priority order. All right, and I think I can illustrate it a couple of times more as we go along when we come to it. Well, in order to do that, we needed three things. The first is we needed some way of simplifying the structure of a big care delivery system like Intermountain. It turns out it's massively complex from a process level. What we did was kind of conceptually break Intermountain into 4 big chunks and then take them one at a time. The first were clinical conditions. So we were looking for work processes that were condition specific, associated directly with some sort of a clinical condition. The second we called clinical support services. We realized that we had a bunch of processes that were not condition specific at all. Pharmacy, imaging, technically anesthesiology, these sorts of things that were of equal importance. We realized that service quality, we call it patient perceptions of quality, seemed to operate by its own set of rules, highly compatible with the same theory, but it seemed to cover everything else. So we thought of it as an orthogonal vector, more on that in a minute. And then it turns out you can treat administration in exactly the same way, just as a series of processes. But we just started to go down through and say, can we identify and prioritize our processes? So first step, break them into 4 big chunks for us, at least, for Dave and me, because, boy, altogether it was too much. And if we played divide and conquer, it really seemed to make sense here. And I'm going to show you the one mostly for the clinical conditions. Second thing, you have to come up with measurable criteria that you'll use to prioritize. Here are the criteria that we used. Number 1, just the number of patients affected. So things that hit a lot of people we thought were more important than things that hit a few people, especially when you roll it in with number 2. We want an assessment of risk to the patient. So kind of severity or intensity. And looking for a way to measure that, the best measure we found was intensity of care. And our best way of estimating intensity of care was true cost, not charge per case. Now, this represents that old Deming dichotomy. Remember how he said that quality and cost are 2 sides of the same coin? Same idea. When we did it on the basis of cost per case, you ended up with a list of processes that if you just took the list of processes and showed them to a room full of physicians and nurses, let's say, and said, hey, this is in terms of order of risk to the patient, it got pretty good traction. You know, people look at it and say, yeah, that makes sense, high face validity. But we tend to spend a lot more on things that we recognize as more seriously dangerous to a patient, or, you know, where there's a bigger opportunity to help, I guess would be the way to say it. Now, yeah, working with a room full of physicians and nurses, we kind of presented it this way. When you walked in with the same data to a room full of administrators, you just talked about it straight up as cost per case. And so we were playing that old game again. And frankly, it works great. And I recommend it very strongly to you. You see, is to speak the language that they know and are responsive to. But that was number 2 factor. Number 3 factor, we argued that something that had a higher rate of variation had a bigger opportunity to improve. So we wanted an estimate of variation. What we used was variation in intensity of care within a particular case type. We used a statistic called coefficient of variation, which is the standard deviation divided by the mean. And it just gives you a way of standardizing out so you get comparables across different processes. It's a commonly used statistic for this purpose in other fields. The 4th item is really the organizational factor we used. You heard Kim say the word, you've heard it in here before too, microsystems. It comes originally from Paul Batalden at Dartmouth. Paul just saw a microsystem as the smallest unitary group of health professionals that could deliver care. So in a clinic setting, it might be a physician, clinical nurse, receptionist, sort of a deal, right? In other settings, it might be another small team, but it's a unit team, if you will. Now, we modified Batalden's idea just a little bit. He kind of saw it as being generic one-offs, right? But we combined Paul's idea with Deming's idea, that you organize everything around value-added frontline work processes. Basically what we said, gee, I wonder if there are microsystems across all of Intermountain that are generic. And we could identify one of these groups, right, by shared work processes. And then we thought that maybe that same set of shared work processes would span across the entire system. So rather than seeing microsystems all as being unique and individual, that they had a very consistent structure based around the shared work processes that define the group. Does that make sense? Turned out it worked great. So Deming's work processes with Batalden's microsystems, and you found that there were replications of the same microsystem that spanned across the entire, at least Intermountain system. And I suspect much more broadly than that, just in passing. You see. Now, the 2 down here, we were having trouble finding really good measures for. But we thought that the idea of equity, social justice, solidarity, focus on underserved populations was a pretty important idea. Didn't know how to directly measure that, but we thought it was important, but it was a judgment call, basically, for that one. And then finally, balance. What I really mean is we wanted something where everybody could move ahead together, where you didn't just have a few groups who were moving and everybody else being left behind. And that was probably the least important, the things we were after. Well, long story short, Dave and I just sat down. Item number 3 you have to have. We started with our hospital campuses, and we just sat down and tried to identify clinical work processes. The reason is our hospital campuses had pretty good data sets. And we did it in conjunction with analyzing them against the factors on that list. Now, the 2 big heavy drivers are the top 2, number of patients times risk to the patient. Now, this is a dollar metric, so you'll see it show up as dollars, but it's really a risk to the patient metric. All right? Initially, we started with DRG categories, which looking back was a bad mistake. I spent an inordinate amount of time ripping apart DRGs on the basis of ICD-9 codes, because many of those DRGs are kind of these polyglot thrown togethers of different clinical work processes, and their only common factor is that they cost about the same, you know, and it was a pain. By 1997, when we updated it for the first time, we'd started to use APR DRGs as our first pass. They tend to be much more clinically based, and you don't have to do nearly as much reconstruction. You still have to do some, just not as much, all right, to get it to the level of work processes. Well, we did that. On our hospital campuses, there's a certain amount of outpatient medicine that takes place, and we included that too because it was all in the same data system, mostly inpatient care, of course. But when we started, I think we had a little over 640 identified clinical work processes that were condition-related. Turns out that 62 of them accounted for 92% of all of our care delivery in terms of volume of patients and intensity of care. This was a surprise. It turned out to not be an 80-20 rule. It turned out to be a better than 90-10 rule. That less than 10% of our clinical work processes were accounting for well over 90% of all of our care delivery. Isn't that interesting? Concentrated like crazy. All right. Well, we just started to analyze them out. Now, when we looked at the work processes that this thing was spitting out, the high priority work processes, we realized that they were in natural families. So this was Batalin's microsystem idea. And we took the natural families defined as groups of physicians and nurses who routinely work together regardless of specialty boundaries or employment boundaries. So anybody who routinely managed the same set of patients together. All right? And we called those natural families or groupings clinical programs. You see, in the past, we'd done service lines inside Intermountain, but that was a marketing concept. And this was management we were trying to put in place, and it was so fundamentally different, we didn't want to get caught in the service line names. So we renamed them, took them from a slightly different approach. And you can see the initial ones in my first pass analysis right here. Now, this is going to modify a bit when we got further down the road. Cardiovascular is the biggest with 18.5% of our total system volume. Neuromusculoskeletal, that's orthopedics, neurosurgery, rehab, 18.4. Surgical specialties, 16.7. Women's newborn, 16.4. Medical specialties, we now call this one intensive medicine. It's hospital-based internal medicine, including hospitalist programs. That's where our ERs live too, 13.5. Intensive pediatrics, hospital-based pediatrics, 6.4. And then intensive behavioral, hospital-based behavioral health, 2.5. Just to give you a feel for it, here's cardiovascular at a detailed level. Here's the family of processes we were putting together. Starts at the top with management of ischemic heart disease. IHD is 10% of our total system volume. Yeah, it's about 57% of cardiovascular, 57% of 18.5% turned out to be 10% of our total system. It's just this one big process. It has 3 sub-processes in it. Chest pain rollout MI in the ER. This is hospital-based after all. That is one major driver to diagnostic and interventional cardiac cath, which then potentially moves on to bypass graft for some patients. Right behind ischemic heart disease is congestive failure, medical management of CHF on a hospital campus. That's the source of most of our valve surgery. and then a very active heart transplant program, nearly always a congestive model. Now, this is a little bit misleading. Bypass graft and valve surgery are actually the same process, just two different tie-ins, tying the pieces together, you see. By the time you get down into this stuff, it's getting pretty small. Arrhythmias and pacemakers, 7.6% of 18.5%. So that's right around the percentage point for the entire system. Peripheral vascular surgery. Oh, a funny thing happened to cancer. You may have noticed on my initial analysis on hospital campuses, cancer didn't make the cut, which really surprised me. But here's what was happening. At a process level, it was getting scooped up. So the process was thoracotomy, regardless of whether you were in the chest after a cancer or a pulmonary bleb or a vascular abnormality. You see, the process was thoracotomy. Similarly, for GI tumors, the process was open peritoneal surgery. And it didn't matter if you're in the gut for diverticulosis or colorectal cancer, you know, at the extreme for a difficult cholecystectomy. Turns out it's a different process in laparoscopic peritoneal surgery. The processes are different. You see? That's what you kind of get. Well, we did that on the hospital campuses. Oh, yeah, maybe the most important thing about this, see this category down here of other cardiovascular, kind of my wastebasket for cardiovascular? There were over 40 of our initial processes in there. 40 of them that accounted for 2.4% of cardiovascular and a small fraction of 1% of our total system volume. All right? About 0.4 of 1%. And we decided to ignore them. See what I mean? That's what I mean when I say organize around the big common things and then free resources to do plans for the uncommon things one at a time. And this turns out to be a fairly hard discipline, just in passing, to be able to ignore something like that. But Dave was really good at it. Doug?
I'm not sure I understand. When you say processes,
Yeah.
things that have similar care type, I lost me a little bit there.
A process is where you, clinical process is where you have a common pattern for caring for the patients, and sometimes it's irrespective of diagnosis, by and large. Many times it follows diagnosis, but sometimes it doesn't. So the process is thoracotomy. And the reason is the work process around that surgery is a nice standard process, and you'll have minor modifications when you're actually in the thorax. But it's pretty much the process is thoracotomy. Does that kind of make sense? Well, yeah, the way we decided it, the process we went through is initially Dave and I, just as a couple of docs, sat down and took our own good pass at it as one surgeon, one internist, right? And then you're going to see our organizational structure start to come online. As we brought up the organizational structure, then we had a much more intense discussion with people who did it every day. Before we'd ask them, but now we got them in a conference room and we're saying, okay, guys, we're almost sure that the way we did it isn't perfect. But how do you think of these work processes? And so as the people who actually delivered the care, we were having that conversation with them, and they said, oh, here's your real process right here. Here's how you think about it. And
the same docs take care of a lot of these patients and they get housed on the same units. So, but they're completely different oncology versus the benign disease. So
yeah,
I see why that.
yeah.
We're a DRG exempt cancer hospital at OSU, so this becomes a huge issue because they've got to be pulled out, despite the fact that they're all housed.
Yeah, so you have to pull them out at OSU just because they're DRG exempt. Huh? You can't house them on the same units. Yeah. Oh, good political move there. I don't know how you got it done, but it's wonderful if you can. That means that they basically have a gold card from CMS. You know, it's awfully nice. You get the idea, though? Now, Rom? Yeah. Yeah.
I'm just going back to the concept of microsystems or clinical care programs and processes. I think that the definition is evolving.
Yeah.
And has implications for
It sure does. Lots of implications for projects, for costs, just how you think about and organize yourself. It has implications for how you put together electronic medical records, too, and things like that. How you physically build a care delivery site. So it has some real implications. And very often what happens, as we'll see in a minute, is that traditional medical staff structures get chewed up by it, too. You know, as you try to understand how best to organize this stuff. Well, we played the same game on an outpatient basis. Dave, of course, had started to run the health plan, and he had some real insights. This was his idea. He said, break it apart into 5 big groups at a population level. The truly well here on the left, this will typically in Utah be about half of a general population of, 100,000 or 500,000 patients. No active disease, no latent risk factors. All right? And there you're really worried about health maintenance prevention. Latent disease means that you've got unmitigated risk factors, basically, or risk factors of some sort. Hypercholesterolemia, not using seatbelts wisely, using tobacco at all, using alcohol poorly, things like that. Now, we did the key process analysis for this and came up with 7 key processes in these 2. We assigned them to Dr. Tamara Lewis, whose office is on the 21st floor of this building, and working with our primary care clinical program, which is yet to show up in this analysis, but it'll be here in a minute, and with our health plan. Well, Tamara's done a wonderful job, won a number of national awards now for things like smoking cessation, immunizations, and so that's where she spends her time, managing those processes. And frankly, at that point, Dave and I ignored them because they were under competent management. And we had our plates kind of full out here. Oh, hospice care here in the far right, terminal patients. Utah has one of the better systems in the country. We could talk about that a little bit. I know a little bit about it. But we chose to focus on acute and chronic conditions for Dave and me. And we defined what we called our community-based care system, where most of this took place, or our primary care clinical program is our other name for the thing. Acute and chronic conditions, same basic analysis with one big gaping hole. We couldn't get our hands on Medicare Part B. All right, so this is commercial insurance that you're looking at. Oh, my little conversation with Dr. Bateman a minute ago, through Health Insight and with Kim's Good Services, we finally got Medicare Part B. And we've got it from the federal government here, and through Health Insights, we're starting to redo this analysis in a very thorough way to update key process analysis. We're going to do it for the state of Utah, then Jack Wenberg and the Dartmouth group, Elliot Fisher, plan to do it for the nation as a whole, using their national database. We just want to see if we can identify and prioritize key processes. All right, basic idea. Yeah, if you look at this, this is adult and pediatric broken out, acute and chronic with a third breakout of some elective down here, adult elective. Remember how the number of patients affected times intensity of care is a dollar metric? That's what's on the x-axis. All right, on an annual basis for this group of patients. Then the size of the bubble is the coefficient of variation. So big bubble means lots of variability, small bubble means not so much. And what you're looking for is big things to the right. You know, like diabetes mellitus, the purple, or the red, hypertension. This is outpatient depression on that light brown. But this is just a way you can sit down together and then say, what order are we going to take these in? Just to anticipate, guys. Single biggest process we operate in Intermountain Healthcare is pregnancy, labor, and delivery. It's 11% of our total system volume. You've heard me say that before. Second biggest is ischemic heart disease. That first year, when we were trying to build our outcomes tracking, guess which 2 processes we did it for? Yeah, our 2 biggest. Pregnancy, labor, and delivery, and ischemic heart disease. And at the end of that year, I could confidently state that 21% of our total campus-based volume was available online as a full set of medical outcomes and intermediate and final forms, cost outcomes, service outcomes, a data set you could actively use to manage. 21% in 1 year. You see, here's the trick. Last year I was working on one for the ER guys in intensive medicine. Tom Garrison chairs the ER development team from up at a KD hospital. They wanted to work on febrile infant in the ER. Well, febrile infant, it really gets the ER guys going because it's a risk of a high-profile death. You get these kids less than 60 days old that show a fever, you're worried about spinal meningitis and potential brain damage, right, or death. The trouble is it took me and mine as much effort to build the outcomes tracking system for febrile infant at maybe, I don't know, 1/10 of 1 percentage point of total system volume. Took as much effort to build that as it did to build pregnancy, labor, and delivery at 11%. Can you see why I would want to do them in size order? So today at Intermountain, we're close to 80% of all of our care delivery being available online as a full set of medical service and cost outcomes data. So that when one of our guys says, in my experience, he means in my measured experience, not in my subjective recall experience, you see. But the only reason we can say that is we did them in size order. And so it's a pretty important idea. It's interesting when you start to get the data how much it drives consensus too. You know, people look at that and they say, yeah, it looks like we need to do diabetes first. So that's the basic idea behind this thing. Now, this next slide is a summary slide. It's a concept, in other words. So don't look for too much detail on it. You won't find it. It's got some errors at that level on it. Just not enough room, frankly. But I just wanted to show you how we ended up thinking about key process analysis. Think of it as a matrix or a grid. The columns in this matrix are clinical condition-based work processes. Now, we've got the campus-based clinical programs running right here. Oh, oncology did pop up as quite important when we added the outpatient component. That's where it really came through strongly. And then we went back and fished out the inpatient components to go with it. Where I know the number of key processes and sub-processes, I put them in parentheses at the bottom. And actually, I need to update the slide because we now are pretty much there for surgical specialties and for intensive peds. The only one that's not yet staffed is intensive behavioral. And I don't think we have a formal analysis there. Well, I've stacked primary care clinical program, community-based care processes on top because usually these things start in the community, then feed through a campus, then back out. This is just the concept that, pay no attention to the number, the concept that there are a series of clinical processes that are executed in a primary care setting that never cross the hospital campus. All right? So if those are the rows in my column, I mean the rows in my, the columns in my matrix, there we go. The rows coming across are clinical support services. So services that are not condition specific, but are still clinical services, clinical work processes. Yeah, pharmacy, imaging, pathology in its various forms, all procedure rooms, ICUs, therapy groups, all nursing units come at this level. All right? No. We hadn't done it. Now, it's a funny thing, again, to get it in perspective, Dave Burton was getting ready to retire. He's since retired. He retired a few months ago and left me all alone. Except that I call him up on the phone and still take foul advantage of him every chance I get. Well, we were talking about a year and a half ago about what the most important thing we could do before Dave retired for his best contribution before he left. And believe it or not, between the two of us, we concluded that the single most important thing we could do is to update the key process analysis from a strategic perspective. So we knew what things we ought to be hitting next in what order to get the maximum leverage for our system and for the patients we serve. All right? Turns out it's surprisingly important when you start to do this. Well, the first time we did it, we focused almost exclusively here on the columns, and this time we just started to go after the rows a bit, more than we ever had before. And the funniest thing happened, we were building conceptual flow diagrams for them, sometimes meeting with the people who actually did the care. We're just building high-order conceptual flows. What we discovered was a series of 5 super processes. They kind of bubbled right to the top of the list, and they were strange. For example, there's a process that we ended up calling substance selection, preparation, and delivery. And it had to do with any substance introduced into the human body by any route. All right? And the big one, of course, is medications, pharmacy. But it also includes, dietary and blood bank. For all of those, the processes were identical, with some relatively minor variations down at a detail level. This has huge implications for IT, for an EMR, just in passing. We had another process that we called information generating. That included all imaging, ClinPath and microbiology, anything that generated information for the clinical team to use. And it had a common process of, let's call it test selection, specimen capture, specimen evaluation, and reporting is the high order of it. But those came together as processes much better than the current groupings that we have, interestingly enough. So that's what we started to see with that, you see. And it looks like this list may simplify a whole lot. By the way, it's an incomplete list. I mostly just ran out of slide. Now, you can use the actual matrix to build what's called an affinity matrix. What you do is you come across and say for these processes who their customers are. So I can tell you for rehab, sniff, TCU, about 50% of the work comes out of neuromusculoskeletal. About another third comes out of cardiovascular. And I've just shown their key relationships where they need to show up, right, attend the meetings, coordinate closely. Some of them, of course, are not that concentrated. Lab tends to run across everybody, as does pharmacy. But you can sometimes see some very tight relationships coming out of this thing, and that's useful. Then we started to organize, when we come to that part, organize this way, organize this way. It was especially this way. You see, these correspond fairly closely to hospital departments. But as soon as I say that these guys are looking at these clinical programs as their customers, it shifts their focus a bit. Classic example, a few years ago, it was between ClinPath at LDS Hospital and cardiovascular. Don LePay runs cardiovascular. He had teams looking at thoracic ICU and extubation times. They were trying to push down length of time in the thoracic ICU, which tied straight to that ventilator. Well, the main test that we use to affect a wean is arterial blood gases. And they'd done some fairly careful analysis and made a compelling argument that they needed results back from ABGs in under 7 minutes for them to be maximally effective. 7 minutes. Turns out that transport time alone to and from the central lab was wiping that one out. You know, even with the tube system, we were in trouble. Well, what LePay and the thoracic surgeons asked for was a peripheral lab up on 7 Northeast at LDS Hospital. You have to understand, though, if I'm the ClinPath manager, Sterling Bennett, Dr. Sterling Bennett in this case, that's a non-starter. And the reason is it will destroy his budget. Sterling just can't run peripheral labs at the same level of efficiency that he can run a single central lab. And you're kind of saying, who's the customer here, right? It's kind of what you're saying. But at least in this case, for the first time in our system, we had somebody who could speak effectively at the organizational level for cardiovascular, who could make the argument, who had a job to oversee it. All right? And it got the right people at the table. Just in passing, the right answer, build a peripheral lab. You'll save so much more up here in terms of your clinical care delivery that it massively justifies the inefficiencies that having the peripheral lab would introduce. Okay? It's the number of key processes.
So is
All right.
this just only one hospital?
This was the entire system.
Okay.
All right. Depending upon the nature of the hospital, though, that's what really determined it. So we get the big quaternaries like Intermountain Medical Center. They'll have some processes that even the other tertiaries don't have. The tertiaries have kind of a shared set of processes, and we go to our level 5. Community hospitals, they have a shared set of processes, and the bigger guys are supersets of that, you see. And so that's how we looked at it. Now, for this to be complete, I have to add 2 more elements. I need a vector coming straight out from the board that's labeled service quality or patient perceptions of quality. And the reason is it uses standard quality principles, but it seems to interact uniformly regardless of which cell of the matrix you're in. Same principles apply anywhere. Then I need to add a layer down at the bottom that the rest of it rests upon called administration, and you can break them into a series of processes too. So that's how you'd handle a big key process analysis. Angela? Nothing? All right. So you see the idea of key process analysis? So a prediction. If you're not there already, the day will come when you and your system is going to want to move out of a project focus. That's great. It can pay your own way. You can achieve some real good with it, right? You'll get more and more people who understand it, but someday your appetite will get to the point where you want to make this systematic. And when you decide that it's time to kind of jump to light speed and make quality a core business strategy, Baldrige style, as it were, at that point, this is the first critical step. What are the key processes we want to manage in what order? Peter?
How's the interface between this COO and individual institutions, these key processes, for the whole system, versus, these only for the key process?
Yeah, so how's the interface between a hospital COO for the whole system and for the individual sites? Coming right up next. All right, we're going to get into management structure next, and you'll see it. All right. What you need to know is that it reports at a regional level within their local hospitals. And the central function is a coordinating function, but of a very particular type. All right. But you'll see that in just a minute. Brian?
I like the graph that you have with the opportunity summary with the bubbles.
Yeah, it's kind of fun, isn't it?
And I could see how you could use that type of a concept in an individual section or department as a microsystem to plan the process before you roll it out across the department or the whole hospital system.
Yeah.
How did you measure variation in terms of determining the size of your bubble? Did you select just a sort of commonsensical approach, different parameters that you thought were important, or are they all evidence-based parameters? How did you do that?
Yeah, the question was how did we figure out the variation within a particular process? So remember what we've done so far is said number of patients within a process times intensity of care as a surrogate for risk to the patient. And that's how we got the positioning along the x-axis. Then the size of the bubble was something called coefficient of variation, and we based it on intensity of care, on cost per case. So it's a direct measure of cost per case. And we just argued highly variant areas, you get just a bigger coefficient of variation. All right, so more variance within that particular case type. So it's pretty important you get the case type to be fairly consistent. Right? And the argument, if I were to say that in process jargon, is that is it the same work process, with minor variations as opposed to something completely different, back and forth. This idea of key process analysis turns out to be fairly important. In a way. So, in a way. Yeah, so you look at things like PEDS general exam. These are well child visits. And it turns out it's fairly big in terms of frequency and intensity, but it has almost no variation, Another funny thing dropped out of this. So for our system in terms of harm to patients, which is more important, the care delivered in the level 1 trauma unit or pregnancy, labor, and delivery? Pregnancy. Turns out that the rate of injury in pregnancy is much, much lower, or the rate of patients coming to harm or to an undesired end. The rate in the shock trauma unit is much higher, but it's a difference between, under 1,000 patients a year in shock trauma and over 30,000 patients a year in pregnancy, labor, and delivery. And so if you look at total number of patients who suffered an undesired outcome, it's actually a little higher in pregnancy, labor, and delivery. It's a funny thing that happens, which is a little counterintuitive, isn't it? In some ways. if you think in terms of individual patients that are harmed.
Now, with those disease specific, how do you account for, multiple?
Yeah. We've encountered that quite dramatically, actually. Well, let me show you a little bit of data. The place where we ran the trial was complex diabetes mellitus in an outpatient setting. It was in a trial evaluating care management nurses technically. So let me skip over and find that really quickly for you. Our geriatricians are our best place to find that, just in passing, because a great many of their patients are complex, you know. So let's think, where did I use that last? If we were talking, let's say, though, to Dr. Sheree Brunker, one of our outstanding geriatricians, she would tell you most of her patients are complex with many different disease processes going on at once. But she would say that if she has the care process model, what it does is it nails down one piece of the mass, right? Now she's going to have to modify it based upon the other chronic diseases, but it will actually make her clinical life a little bit simpler. So in the trial, with patients, I think, that had a minimum of 3 comorbid illnesses, using the diabetes care process model and care management nurses resulted in the 2-year hospitalization rate falling from 39 to 31%, which is significant. It resulted in, this is a proportion alive, let's say at 3 years, a significant difference in mortality rates. Fewer people died. This is mostly the effect of the care management nurses, but a substantial jump in physician productivity. All right? And it came from using a care process model. That's what it boils down to. Okay? And what it does, Peter, is you take a complex area, you know, multiple comorbid diseases, where you got to worry about this and this and this and this, and there's just all these degrees of freedom and all this stuff going on, and just taking one of them off the table effectively by standardizing it a bit makes a big difference. So this is what we heard back verbally from our geriatricians in complex cases, and what we saw then when we started to run trials like this is you saw they were right. It was making significant differences in care. Kind of makes sense, doesn't it? You know? And Cherie actually makes the argument that she thinks that our care process models are the most important for complex patients. She says, oh, just plain old diabetes would be really easy. She says, but when you've got several diseases running at once, that's where they help the most.
So your outpatient care management process, those are run by the mid-level providers?
Yeah, what happened is as we started to run these trials, so this is a randomized trial, and what we saw was that the care process models produce better care at a cheaper rate, and that we could really enhance our care process models. And so what you're seeing is an early version of the medical home. And so we tested putting care management nurses in primary clinics as our primary source of care management. So this is a clinical feature now, not something that some insurance company does, right? And it seemed to have one heck of an impact while offloading the physicians. You see? And in fact, the results were impressive enough that our Intermountain Medical Group, which is about 2/3 primary care, Linda Leckman, surgeon who ran it, and Phil White, the administrator she stole from me, darn good administrator, that Linda stole from the Institute years ago. They decided to put care management nurses in every clinic. And they've been building into that ever since. It's a little bit of a financial challenge. But it's based off data like these. Now, I honestly think the care management nurses, without the care process models, I don't think they would have worked nearly as well. But as a combination, they work great. So we can show pretty big boost just with the care process model. Throw that in with the care management nurse and some magic happens. Who was saying it's magic earlier? You know? So that's what we saw. Initially, it was verbal reports coming back from some of our geriatricians. And then later, we started to get data back like these. So looks like it's a pretty good model, if that makes sense. I'll tell you what, this is a great place for a break. Before I let you take a quick break and stretch and wake up a bit and get some food on the back table, any questions about key process analysis? I'll admit to a long-term failure around this issue. Knowing how important it is, I've never been able to see, well, never impress members of the class to just go home and start to do it immediately. And I don't know why. Maybe it's because you have to be basically an analytic geek to really want to do it. So, but it turns out to be really useful. Peter?
Without, you gave me the chronological order, but without building that measurements, you would not be able to do the key process analysis.
Well, we actually had enough data to do key process analysis to bootstrap ourselves up and get started. And then, of course, what happens is it cycles on itself. And you start to get a lot better data, and so every year we try to update the key process analysis. Now, with the Medicare Part B data coming available, we're going to invest some very serious resources in it and try to get something moderately definitive. It turned out it was really hard. And one of the reasons is it had never been done before in healthcare. So you didn't have much of a structure to work from. And anytime you're in that circumstance, we'll do this. And what I really hope is then some others out in the profession will get interested in it, and we'll see substantial improvement in it over time. And it'll become more of a common way of thinking about how we do our work. Because it sure is functional. Works great.
So are you not using more of the claims data than clinical data?
Well, back then we didn't have the clinical data to speak of. But these days we'd use more of the clinical data. Because we have it now. So I've just been doing this with our intensive peds group, and what we did is we got as good a data as we could from the hospital, some of it really pretty good. And a couple of us sat down and did a first pass as knowledgeable individuals, but not experts in the field. You hate to give them a blank sheet of paper on the first pass, and we kind of defined what we thought might be work processes plus or minus, right? And we racked up about 80 of them. And it turns out they were concentrating like crazy into a relative handful. I want to say initially I think we had 12. Then we sat down a bunch of our hospitalists and some of the nurses and some of the clinical leadership, and various and sundry others, and got them in a room together, and we poured over the reports, and a lot of pushback and saying, well, under this name of this process, what are the ICD-9 codes that go with that? And a lot of people said, well, that's really not how I think of it as a practicing physician. We really ought to reclassify it this way. And so we did a fair bit of juggling like that. But you ended up with a pretty good sound list of here's the priority order. Now my guess is if we work with it for a year and people get more accustomed to it and we come back and redo it in another year, which we will do, that they'll have some real insights, and what do you bet it changes a bit? You sure hope so, wouldn't you? And then over a period of time you get something that's pretty darn tight. You see? And lots more people start to think about it that way, and so you get the intellectual contribution of a much broader base putting it together. So that's what you'd really like to see. You can come pretty close by guessing. So the common way that we've done this thing nationally is we get a bunch of experts together and we say what's most important. And you kind of subject to recall seat of the pantsit is what happens with the thing. Well, served on an IOM committee, and George Isham from Minnesota chaired it. But that's what they basically decided to do. I tried to convince them we ought to go out and try to do it analytically, but they did it based upon expert opinion. And basically what you get is, Healthy America 2010, when you start to do it on the basis of expert opinion. Which is not bad, actually. They'll get most of it, but then you get these subtleties that you didn't expect. So here's a subtlety, guys. See this thing? By that point, we had made a decision. We had already started a couple of our development teams, as you'll see in a minute, to put together the care management systems around these. And just based upon common knowledge among the experts, we had started asthma, outpatient asthma as one of them. When Dave and I did the analysis, asthma didn't make the cut, which was something of a surprise. On the inpatient side, it didn't make the cut either. The only place where it did make the cut was at primary children's. All right? And let's just say we would have used a different approach if we'd done the analysis before we started. So that was kind of a ready, fire, aim sort of a deal. And you bootstrap yourself up. You do a first pass, and you start to organize around it a bit, and then that gives you enough data to make a much tighter second pass, and then over time you get with something that's fairly reliable. It's the basic idea behind the thing. Well, ready for a break? See you back in 15 minutes or so. When we left off, we were working our way slowly, sleepily through this idea of a system for management. We talked about key process analysis. The next big chunk I need to show you is the management structure. This is largely Dave Burton's work. I wish I'd kept the first 4 or 5 versions, by the way. We were really good at adapting, kind of rapid cycle style of trying things and making fast changes, you know, pilots and then changes and pilots and then changes. But this is the one that stuck. So we had these clinical programs, right? These microsystems that spread across the entire system. And what Dave did one day as we sat down, and we did something called a thought leader, somebody who could lead within the profession. Number 3, they had to be at that point in their career where they move into a management role or some sort of a leadership role. Now, there's a requirement that these folks all graduate from this class. And on top of that, we have a leadership series. Again, it's a modified form of that NBA over time to just give them skills and support over time. But in each region then, for each of the clinical programs, 2 people. Full-time, well, we call them clinical operations administrators because they're on the clinical ops side. Most of them are nurses. There's a physical therapist, a couple of others, but mostly nurses. And then a physician as well. Just to illustrate, in cardiovascular medicine, Urban North region, it's Steve Kane. He's a thoracic surgeon in community practice. We bought a quarter of his time from his practice by contract. In fact, about 2/3 of the medical directors are community-based, as opposed to employed through the Intermountain Medical Group or through a hospital. Central region in cardiovascular, it's Don LePay. He was a community-based interventional cardiologist. His group just joined the system. Bill recently voted to join the system, so he'll shift status, I guess. And finally, in the Urban South region, it was John Frizhnek, a non-interventional cardiologist. He retired a while ago, and I can't remember who's replaced him, and then I'd have to check to get the guy down in the Southwest region now. But each of them had a nurse administrator with them. In primary care medicine, it was Jerry Gardner in the North region. Family medicine, Central region, it's Wayne Cannon. Pediatrics, South region, Von Welch, internal medicine. You see the idea. Mary Jo?
So each specialty had its own point of a director and a full-time nurse.
That's correct. And we think of them as clinical programs. I guess you could think of them as specialties, but they often combine specialties. So in cardiovascular, it's mostly thoracic surgeons and cardiologists at a physician level. All right? So it's not traditional department lines. In one of our regions, the basic structure in a region will nearly always have a big tertiary, and then a series of somewhere between 2 and 6 community-level hospitals, right? And then down below that, we have a network of group practices, solo practices, a primary care network, and a specialty referral group nearly always back behind that in each region. So we're regionalized that way. You see the idea? Now, don't get the wrong thought. It's not that we just went out and hired all of these people all at once. We brought up the clinical programs one at a time and then would staff them in a region as we had the data ready and the structure so that they could be effective. And so we tended to add them in 1s and 2s over time. And it affects the way that you budget for these things, just in passing. And so that's been coming up. I think it took us 8 years to get to the point where we had everything now but behavioral health up and staffed across the system. But a medical director, a ClinOps administrator in each region for each clinical program. It's the basic idea behind this thing. So we'll come back and talk about staffing in just a minute overall. Oh, their basic job description. First task, we ask that they meet each month with any clinical team in their region that is executing any of the processes for which they are accountable. Now, half, 2/3 of those practices are going to be community-based independent physicians, not employed. It's kind of the form of a giant staff meeting, except that at this staff meeting, very often support staff shows up too, not just the physicians. Basic order of march, they tend to bring a notebook computer, a computer projector, tie it into our internal web, kick the outcomes data up on the wall, where you can track how we're doing for our patients around each of these processes. We can drill it down to the level of an individual practice if necessary, and just look at how we're doing. Oh, we use this structure to set goals, improvement goals each year. More on that in a minute. But a fair bit of the time is spent on progress on goals, what barriers people are encountering, challenges, special needs to make that good care happen on a broad scale, you see. So a fairly classic management structure, actually, as far as that goes. But it's based around shared professional values, under the belief that all of those frontline teams, what they really want is best care for their patients and then reasonable reimbursement for doing that. You know, it's what you're really after. And that's the heart of the partnership, is best care with reasonable reimbursement. And it is a partnership because there are no real control mechanisms involved. Well, after these teams, these dyads, meet with their frontline colleagues, it's usually one big meeting and then usually a series of smaller meetings. They go back and meet with their regional administration. Technically, these folks are funded out of the region, and they report to the regional vice president. So they report at a regional level in the system. They're technically part of regional administration. Yeah, we call them regional operating councils, ROCs. It'll be each of the clinical programs in the region will be around the table. The administrators, usually the regional vice president will assign an assistant administrator to each of the clinical program groups, so it's a triad at that level of a administrator, nursing leader, a physician leader, right? It's the organizational group. But it's a fairly classic accountability meeting. They'll load up and kick up how we're doing on outcomes, service cost, clinical outcomes, but then they'll spend a lot of time on goal achievement and what resources are needed and how progress is being made, you see. You got to remember, I told you last time how we're on an incentive withhold basically for our pay. Well, those regional vice presidents and hospital administrators are on the same system, and about half of their withhold will be based upon meeting these goals right here. So it tends to keep people fairly well focused on what we think is important together as a group. All right. Well, yeah, number one, meet with your frontline colleagues. Number two, you're part of the regional organization, so meet with your regional organization. Oh, I neglected to mention, in Iraq, we'll also nearly always see finance there. Regional IT will be there. Quality management nursing will be there. So just a standard accountability coordination meeting. Now, after they've met in their region, once a month, we also all get together here centrally in what's called guidance council. Nice quality term for the thing. It's the coordinating group for the entire system. So even though their direct line of report was in their region, they have kind of a dotted line up to the system. All right? Oh, we'll take one of the physician medical directors from the 4 regions by another 1/4 of that individual's time from their practice, and they become the system-wide clinical program leader. All right? For the entire system. Oh, we need to give them a clinical ops administrator. Of course, all these people at the regional level are full-time already. So what we do is hire another full-time clinical ops administrator for system-wide coordination. So full-time, quarter-time, same as down below, you see. And in fact, some of you have been asking me about some of the clinical entities here, and what I very often do is send you up one floor to where all of the clinical program folks reside. So if it were women's newborn, I send you to see Jenny Wilson. If it was cardiovascular, that's Colleen Richards. You know, if it's primary care, it's Eileen Tippett, and so on down the list. because they're full-time and easy to make those contacts. We meet together once a month. In addition to the leadership group, I assign each clinical program at least one, sometimes two, master's level or higher statisticians to help with analytic work within the clinical program, not just for the group as a whole, system-wide, but also for regional needs, if there are special regional needs. We give them each one, sometimes two, data managers to help with data preparation and flows. More on that as we come to that later in the course. All right. In this meeting, we nearly always get corporate level finance, corporate level IT. This is where we coordinate a lot of corporate level IT, back and forth, quality management, nursing. But yeah, we meet every month, a huge amount of sharing back and forth of here are the problems we've encountered, here's what to watch out for, here's what's worked, here's what hasn't worked. So just a lot of cross support, people helping each other out back and forth. Oh, this is the point at which we actually set goals. So each year in June and July, these frontline people will be identifying targets of opportunity where we think we have our biggest opportunities to improve. We'll bundle it together into goals that then get pumped up the line. Clinical operations leadership team is where these report. It's a senior leadership team. And that bumps back to our board of trustees. That process is called hoshin in the Japanese, or catch ball, and you go back and forth a little bit until you end up typically with a set of between 2 and 4 board level goals for each clinical program. They tend to be little dyads of a clinical outcomes goal with an associated cost savings goal. And then usually in addition to the board level goals, they'll have, 4 to 8 additional just clinical program level goals they set for themselves, very often implementation goals. Back and forth, all right? But a lot of sharing, a lot of cross support going along. So you see the basic structure for this thing, how it works. It's a relatively large number of people. In terms of physicians, I've got 1, 2, 3, 4, 5 quarter-time FTEs for physicians for each of 9 clinical programs. So 9 times 5 is 45, divided by 4 is 11 and a quarter FTEs for physician leadership when it's fully staffed all the way. I have 45 clinical ops administrators full-time. Currently we have 10 statisticians and 10 data managers. As I'll show you in a minute, we have Tracy Veo and 9 people just for educational materials. It comes down that on the directly funded side, it's about 90 FTEs. Currently, to run this thing, about $5 million a year in salary. All right, for that part of the funding. Sometimes some of my administrative colleagues push back pretty hard on that. They say 90 FTEs is an awful lot. My favorite thing to do is to just make a little point. I say, our core business is clinical care delivery. We got 90 FTEs that's managing over 80% of all of our clinical care delivery. Let's compare it to how well we're doing on the facilities side. You have over 500 people to manage the facilities. Looks to me like you probably have a few too many people, frankly, given how parsimonious we're being on the clinical side. But, it's because we didn't accrete up over time. We kind of plan it from scratch, and it's still pretty darn lean. Now, there's a technique you're seeing here. What you're trying to do is change the fundamental management structure. But you can't just, drop the old one and shift to a new one. You need the old one. So what you do is you do two in parallel. You build up the new one in parallel with the old one, give them lots of cross links. Then over time, they tend to collapse into each other. And that's what's been happening. We've watched as more and more the regional vice presidents have come to rely more and more heavily on their clinical program leaders in their regions for medical staff relations, for clinical management, for supply, for medical staff problems, for just many, many different things within their region. And so we see those things merging together and kind of finding their own right level right now. As you start to build a joint structure that manages not just the facility but the clinical care delivery and hopefully takes care of the trade-offs back and forth between them in a wise and intelligent way. Now, in truth, the part that we have not done yet, we haven't really hit this side hard. And my guess is that's the next big step, is to start to organize the clinical support services in the same way. We've seen some progress on that, but I think we've still got a ways to go and fundamentally overhaul the way that we think about our hospital departments and our clinical support departments in an outpatient setting. Mary Jo?
So, Brent, where then is the CEO of all Intermountain?
Technically, there's a small layer here called Management Committee of 4 individuals. And so he's here technically between, it's funny because it nearly always goes Colt, and then Bill doesn't get very heavily involved, but it goes to the board. So I guess he gets involved in taking a look at it before it goes to the board. But yeah, it tends to bounce from Colt pretty much to the board in terms of approvals.
So
All right.
is there alignment then between the whole, the guidance council, technically reports to the clinical ops leadership team,
Right.
yet they work independently?
Yeah. They, except for this guy, these two right here are part of the central structure. But all of these folks down here are reporting to the regional vice presidents. Oh, this group right here, what it's really made up of is our governance structure inside Intermountain. In each of the regions, we have a chief nursing officer, a chief administrative officer, and a chief medical officer. And those little triads are the regional management team, right? And that's Colt. Okay. So there's kind of a dual role there. So people who are running a region then show up on Colt where we coordinate system-wide in the same sort of a way. You see? So, but that goes up to our senior board of trustees. Technically, Intermountain has one parent board of trustees, and then we have, what do we call them, advisory boards in each of the hospitals, local community advisory boards. But the group who holds all of the official legal authority, wisely, because you want to give the local boards due credit, but it is the parent board. You see? Parent board level. That's just how we're organized. It works out pretty well. At the site level, they'll have a board of trustees, but it's technically an advisory board, but still gets, let's just say, a lot of attention to the things that they say at a regional level, right? And then that regional administration. Yeah, they'd have a regional vice president, chief nursing officer, chief medical officer. So. Yeah, I think that's correct. So it's just a way of tying the entire system together, you see. Now there's one part of this I haven't talked about yet. It's this group right here. And this turns out to be critically important. They're called development teams. So each of the guidance councils, each of the clinical programs is another way of saying it, has several development teams. This will be a little bit inaccurate, but a development team exists for each of the care processes we have under management. A development team owns each of the care processes. So let's think if I can name them all for primary care. They are adult asthma, peds asthma, diabetes mellitus, congestive heart failure, community-acquired pneumonia, antibiotics and bronchiolitis, depression, hypertension. Did I say chronic anticoagulation yet? And otitis media. I got all 10. Currently, we have 10 up in size order. Believe it or not, when they're all fully there, there'd be about 40. So it's big, you see. But development teams that then report in to this group. In cardiovascular, they have a relatively small structure. They have the ischemic heart disease team, the congestive heart failure team, the arrhythmias and pacemakers team, and the cardiac surgery team, as I recall. it's even simpler in women's and newborn, where there are really only 3 and 2 only really active ones at the moment. The OB development team, pregnancy, labor, and delivery development team, in other words, right? And the NICU team. And then the third one is abnormal uterine bleeding, hysterectomy, basically. It's the main procedure associated with that. So there you go. But each of these has that kind of a structure underneath. Well, a development team has a particular structure. You have a team leader who's usually a respected physician authority in the area, appointed to head the team. Then the next group, we call them core work group, or sometimes we call them knowledge experts. They tend to be specialists. And we try to pick one from each region when it's fully staffed, sometimes 2, as you'll see, depending upon the workload. But we purposefully try to keep it to a very small group, 3 to 5 people, maybe, 6 at the outside. The reason is they're going to be the main worker bees for getting stuff done, and the smaller group just works a lot faster. But what happens then is this core work group, the time commitment may be 4 hours a week for this group, but they report back to an actual development team that's technically made up of frontline clinicians, not just physicians, but also nurses, occasionally a clerk, fundamental knowledge. Development teams actually correspond very closely to an improvement team. Remember the structure that I showed you where you have the team that represents fundamental knowledge pulled up? Well, imagine that that's what I have. The fundamental knowledge from these folks is how it actually happens, what's the workflows and the work processes. These folks, the core work group, they're the experts in terms of understanding the best science and the best medicine, as you'll see in just a minute. All right? So here you have that development team structure with a leader, a core work group, full development team reporting in, and they're a standard quality improvement team. So the people on the development team, it's their job to take this back to their region and share it with their colleagues, just like we talked about last time. And not just bring fundamental knowledge up, but take the findings of the team back out and maintain that two-way street. It's the basic idea. Well, yeah, what we do usually, we call together a development team, and the first part of their existence is to develop the initial evidence-based best practice guideline in an executable form. Now, we call those things care process models, and they have 5 major elements within them. So element number 1, you sit down and flow chart out evidence-based best practice, usually. The core work group tends to do it. And then as the core work group produces this, we send it out to the whole development team. We meet about it, right? What would you change? The reason that you have the core work group report to frontline practitioners is that it helps you avoid the ivory tower syndrome, people coming up with solutions that are not implementable, which otherwise is not that infrequent. So you want to temper your specialists with a little reality, frontline reality there, frankly. And so it's structured to do that. Now, as you get the evidence-based best practice guideline off the boards and starting to move, you use it to then start to blend the guideline into clinical workflow. Again, the main heavy work is done by the core work group, but a lot of staff support, but then feeding back to these frontline teams. Well, actually, you heard Kim talk about it. How did they get that community-acquired pneumonia protocol into a usable form? Well, it was Kim and his partners and nurses who did it. And the reason is they were living it every day, and they could do a pretty good rapid cycle on something that worked for them. Now, turns out that this is a moderately hard job. This is why you really want those experts, is for step 1. This is harder. Getting it into an executable form is actually a bit more work, a bit harder. But we've had the fortune over the years where we found 7 or 8 different formats that work. And you saw Kim's, where he had that kind of clinical note that showed the flow, the logic flow of it, and collected data at the same time. And then it fed into a standing order set. Well, very often one of the representations of this is a standing order set. And sometimes it's clinical flow sheets that collect data as it steps you through the logic at the same time. But remember, we're going to use them as shared baselines, so people have to be able to vary based upon need. Then you have to be able to track the variances with them. Well, as this comes together, we come in with a fair bit of staff support, actually, and we start to build an outcomes tracking data system. to identify and build measures around major, intermediate, and final medical outcomes, service outcomes, and cost outcomes. So that happens right here. Now I'm going to go through this in detail. Looks like the way the time is going, probably on Thursday afternoon. All right. Oh, yeah, that's how we figure out what goes into the electronic medical record. Sometimes the electronic medical record will lag the initial work, though, by 3 or 4 years. Just takes that long at the present moment to get it programmed in. We're in the midst of a major redesign of our EMR to shorten that time down massively to where we could get it in a week as opposed to years. But that's not yet ready to run, so there's often a lag, and you run it on a paper form in the meantime. Yeah, finally, I mentioned Tracy Veo and her people. We design a standard educational packet for the patients and their families, and also for the professional group. Well, a fairly broad array of support materials. It's funny, Tracy has 9 people. We're not at all shy about buying things. No sense in reinventing the wheel or stealing anything that's not nailed down, and it's still a major effort to keep that packaged up and going out that way in a nice standard format. Well, those 5 elements are what we call a care process model. The reason they're all listed there is because if we didn't have all 5, we couldn't implement. That's what it took to actually implement one of these things. All right? Was to think about those elements of it, at least. You might be able to come up with a slightly different list, but I bet you'd have same basic function, at least, within it, in terms of the pieces you need to get a deployable shared baseline. Now, as this thing comes off the boards, of course, they're building it, and, well, that development team leader is tying into the team's management group. So this is exactly like what I showed you about team structure. So they're taking the outputs from the development team and reporting back each time the guidance council meets. And when you finally get it finished and approved, of course, they're trying to lay some groundwork with these frontline folks out here as they work. But technically it deploys out through these dyads. So when I talk about them meeting with frontline teams and deploying goals, very often early goals would be to just deploy out and get in place and running one of these care process models to bring that particular clinical area under management. Now, something in case you missed it, we have one of these for the entire system. We basically don't allow each region to have their own, or each hospital to have their own, or worse still, each physician to have their own. There's one. And we change it as a group. We learn together as a group, and we change it as a group. One for the entire system. Frankly, given the size of Intermountain, I just can't imagine trying to have more than one for the same entity. Really can't. Be a nightmare. Try to coordinate means you couldn't learn from each other. Once the development team has a care process model out in active use and now data are flowing from it, their role changes. And we move out of a development phase into a maintenance phase, but they continue to meet every month. The main people on the team, by the way, the main bulk of the team, these frontline clinicians, we pay for their time too. So if they're not employed by the system, we pay for their time to attend the meetings, including travel time. Just to take the burden away. We don't pay very well, but it's basically a fair price for time away from your clinical work, as close as we can tell, for those who are interested enough to participate. So we don't ask you to do it on your own, you see.
But is it in addition to your expectation for 40-hour week, for example? This would be, or would that be?
Well, if they're employed by us, it's just part of their work time. Yeah.
In essence, then they're getting a bonus.
Well, no, this would just be part of their job. But if about 2/3 of these people are community-based, they're not employed by us. And so those folks, we pay for their time. We don't ask them just to do it for free if they're not employed by us, right?
So most of those people then would be physicians?
Some of them, yeah, most of them physicians, but we also tend to pick up a fair number of nurses and a fair number of just like clerks or other people with fundamental knowledge at the front line. Depends on the process a little bit. But you get the right fundamental knowledge just like you would on any improvement team who understand steps in the process and how it ought to work. Just so that you have the right knowledge on your group.
Do these people stay in that group only until that one particular process is up and running?
No, they tend to stay forever. There's turnover on it. Some people get tired of it and want to go away. They'll move away. They'll retire. And so there's always a certain amount of turnover. To be honest, there are some who don't show up, and then the team leader says, well, if you're not going to show up, we really ought to replace you. You know? And so there's some turnover, but usually it's a fairly long-term commitment if you choose to stay and you produce well. You see? You know, currently, the guy, Kim Bateman, talked to you about community-acquired pneumonia. The person who chairs that's Nat Dean, pulmonologist from Intermountain Medical Center, but Nat's been doing that now for over 10 years. You know, pretty constant. Now, there's another structure you're going to see down below here, and it explains the continuity a bit. It's during the maintenance phase. Well, remember how we treat these as shared baselines in a learning structure? So people are varying from it fairly routinely. Well, you got to track the variances to learn from them. That's what this team does. So after it's deployed out and running, every month the development team meets and, well, they look at protocol variations. In addition, and this is important, the experts on the team, the specialists, have through their team assignment a certain amount of protected time. It's their job to keep us up to date on state-of-the-art in research. All right? And it actually goes a step beyond just knowing what's in the published research literature. I expect them to know what's in the research pipeline. If they're actively engaged with the research groups around the country, they'll know a year to 2 years in advance what's coming so that we can prepare for it. Now, I'm going to talk about this as a knowledge management function. And what you're going to see happening right in here is you're going to see a group of people, that core work group on a development team, who have protected time. The way I say it is to go kill it and drag it home for the rest of us. So for diabetes mellitus, for example, rather than expecting every primary care physician in Intermountain to somehow keep themselves current on diabetes and 39 other key processes in their practice, it's some of the most complex medicine we do, by the way, in a primary care setting, just because there's so many of them. Rather than read the journals, attend the meetings, you know, stay current on their own, we have these guys, and it's their job to know what it is, bring it home, package it up, and push it out. And the push-out piece comes right here. It's the job of the specialist to academically detail the front line. Before I leave this one, though, yeah, you look at what's in the research pipeline, you look at your own protocol variations, you look at your outcomes, right? And then the other interesting thing is you'll get, from people at the front line who do this every day, you'll just get good ideas from time to time. And people will say, well, you know, we really ought to be doing it this way. And that's where those ideas should come. Now, the fact is it's a group enterprise. Well, as a result of that, our protocols tend to change every month. When you have this kind of a group overseeing it actively, there's nearly always some learning going on and some tests of change going on, right? Just because of how you structured the group, and that's their job. Yeah, Kim probably mentioned it to you. With community-acquired pneumonia, an awful lot of it is just keeping track of current antibiotics, and what do we call those, antibiotograms, I guess, of resistance patterns in the community. But there are new things coming out in research, and of course you're tracking compliances to see how the thing's serving. But that's where the structure all comes together. Now, yeah, we call them clinical learning days. They typically happen 2, 3, 4 times within a region per year. It'll usually be a Saturday, for the primary care example at least. But what we do is ask the specialists. This is why we want one specialist for region as the core work group, at least one. They'll come do a CME session as part of that on diabetes, on chronic anticoagulation, on CHF, on otitis, on asthma, right? And so they do a CME session, and the guys, the men and women who treat those patients can just sign up and get current state-of-the-art. So again, rather than asking each primary care physician to stay at state-of-the-art on their own, we have designated people whose job it is to supply that information. Oh, in an integrated way, I've sat in on a bunch of those, and we'll nearly always start with evidence-based best practice. Here's how it looks in workflow in the clinics where we put it in place. Here's how it looks in your own outcome data. Here's how it looks in the EMR. Here's how it looks in the educational materials. So you have a fully coordinated set of tools for deploying that thing out. Now, just so you'll know, the original reason we started doing this, we kind of grew into it, was to manage referrals within the system. We saw it as a referral management network. Well, first time I encountered it, I was up at McKay-Dee Hospital years ago. I was over CME, and we were running some CME sessions up there. What I watched was one of our new young orthopedic surgeons in the community. This guy wanted to specialize in shoulder injuries. There were two other guys who were trying to specialize in shoulder injuries in the community up there at the same time. Well, I watched him take about 40 primary care physicians and put them through an hour and a half of CME on how to manage shoulder injuries to a bunch of primary care guys, right? And he did a dang good job of it. By the time he was done, I thought that I could manage shoulder injuries pretty effectively at a primary care level. Well, he got all done. Everybody was pretty happy. The group was breaking up and went up to say thanks, and the medical director of the hospital was there talking to him, congratulating him on a very fine presentation. And he said, George, he says, he just gave away half your practice. And the guy had the most classic response. He said, I may have given away half a practice, but I bet it wasn't mine. He said, I've been here long enough to know that the primary care folks are sending me a lot of cases that I just as soon not see, that really should be managed at a primary care level. They're not comfortable. They're not confident in handling them. He said, what I really want them to do is handle this first level of cases themselves and then feed me the cases that need surgery, so I spend most of my time in surgery. He says, that's where I'm most remunerative. That's where it works out best for me. He said, if I teach them how to manage shoulder injuries, he said, I think they'll have more fun in their practice. It's a way for them to do well too. But he says, I think they'll send me all of their good surgical cases. And I realized I was just seeing the guy who was going to be the successful shoulder specialist in Ogden. That's what I was seeing. And he had realized that primary care referral network, right, was, well, if not his primary customer, that may have been the patient, should have been the patient, at least was a major secondary customer. He was treating them like that. And so our initial attempt was just to build that in here as a means of managing referrals within the system, right? It was up and running for a while before we realized that we had effectively done the way I currently think of it as a lifelong residency training program, where if you're practicing medicine just in the community but associated with Intermountain, right, that we have some designated people whose job it is to get current state-of-the-art, package it up, push it out in a usable format, just like you're in a lifelong residency. And we came to recognize that this is fundamentally a knowledge management function. Remember how we talked about the doubling time of medical knowledge now being, 8 years, maybe as low as 5? And I asked, how is it if you have to learn, then unlearn, and relearn half of your medical knowledge base 5 times in the course of a career? How are you going to do it? I think it moves out beyond where a single individual can do it, but it's to the point where an organization can make a major contribution, but it takes an organization to package and deliver the knowledge consistently. So with this structure, I don't think it should take 20 years for major new research finding to make it out into widespread use. I think if we find one that looks like a real winner, it should be out in use within 6 months, as opposed to a 20-year lag. But that takes an organization, doesn't it? And people with a specific role and some salary support to do it. Well, the final thing they do is they manage specialist care managers. Now, one other little thing you need to know with this structure, for most of the big chronic diseases we manage, where this really shines, like diabetes, I was showing you that care management data with the care management nurses for diabetes. Well, this is where it's coming from, right here, out of this structure. We call them treatment cascades. And often at the core of the care process model is a series of escalating steps of therapy. So diabetes mellitus, I've got to control blood sugars, hypertension, and lipids, right? So just for blood sugars, well, we start with very thorough patient education on diet, exercise, medications to control their own condition. So the patient's the first line caregiver in their own treatment, right, is what you're after. And we buff it up through those specialist care managers embedded, in this case it'd be diabetic educators embedded in the diabetologist practices. Well, then I think they start with metformin, an oral hypoglycemic for type 2 diabetes. If they get good sugar control with that, you hold them. If you don't, then you drop to a sulfonylurea. They have a designated sulfonylurea in the care process model. If you get good control with that, you hold them. Otherwise, you drop. I think it's the next combined therapy of metformin plus a sulfonylurea. So at each step, you're getting a little bit more danger, more risk in the treatment, right? But justified now, and a little bit more expense. I think the next level is simple insulins into complex insulins. The last step in most of the treatment cascades is referral to the specialist. And so when I say that the specialists run the referral clinics, they tend to be the last stop on an outcomes chain. All right? Because of this, currently 6 diabetologists manage about 30,000 diabetics inside Intermountain. Just under 90% of all the care is delivered in primary care offices, and they achieve state-of-the-art care that would go up against any specialty practice that I've ever seen. But it's because they have that kind of support in place, right? Oh, crazy thing, guys. Our diabetologists have worse outcome statistics than most of our primary care practices. And the reason is we're concentrating the really hard cases in the diabetology practices, which is kind of how we think specialists work. We think that's what they signed up for when they came on board, was to handle the tough ones, right? Not the easy ones. If I go back to Boston, for example, where I'm somewhat familiar with the practice structure, almost all diabetics are seen by endocrinologists, but the endocrinologists are managing the simple, easy cases at massive expense. Good result, but at massive expense. Well, we'll have equivalent outcomes. It's just that most of ours is done in a primary care network with the medical home. You see, as opposed to fragmenting the care across a group of specialists. Kind of makes sense? So maybe the key thing in this whole structure are the development teams that own specific care processes and manage them over time. And we think of it as a knowledge management function. Thoughts, issues? You've seen the structure now, Peter.
You mentioned about this body of 90 people managing about 80% of the clinical processes.
Yeah.
And then you also talk about building up parallel.
Uh-huh. And letting it collapse into each other.
How does the collapse work? That's the key, because the autonomy, the
Yeah.
stability at the site level versus the regional.
It's happened 2 ways. The first way, so Dave and I were just happily going about our business, right? Building the parallel structure. One day we hear that there's been a bit of turmoil up at McKay-D. What had happened was that the thoracic surgeons had pulled themselves out of the Department of Surgery. The cardiologists had pulled themselves out of the Department of Internal Medicine. And these guys had created their own independent Department of Cardiovascular Medicine. Now, in our community hospitals, under our medical staff bylaws, if some N number, I don't know what the number is, certain number of doctors want to, they can just form their own department and elect their own department chair. Their discretion, right? So that's what they did. It's fair to say that this created a certain amount of turmoil at the hospital. Well, as chance would have it, one of the thoracic surgeons was in this class at the time. And I heard about this happening, and then we were meeting in ATP. It wasn't Steve Kane, it was one of the younger surgeons who was in his group. So I asked him, I said, Mark, what are you guys doing? And he said, well, Brent, he said, you got to understand. He said, when I'd go to Department of Surgery meetings, if I was lucky, 20%, maybe 25% of what they discussed had anything to do with me at all. And he says, that's why I tried to duck them every time I got a chance. I had to attend a certain minimum number just to stay privileged, but it wasn't on the high priority list for me, pretty empty time. He said, the difference is when I meet with this group, he said, I'd guess it's 80 or 90% of what they discuss is relevant to me. That's what happens when you start to define groups around shared work processes who routinely work together this way. Oh, they formed themselves in a new department, then they proceeded to elect the guy that we were paying to be the clinical program leader as their department chair. They figured that it fit for Steve because he had paid time to do it, which otherwise he didn't have. It was a voluntary role otherwise. And the next thing you know, that kind of replicated across the entire system. And we started to kind of point it toward people, but the funny thing is we didn't even start it. That was on the medical staff side. And we watched this happen in a number of other areas where departments started to realign around clinical program structure because of the shared work processes. The most prominent was cardiovascular. But it was just more functional for people. Well, meanwhile, so what we saw happening is in many circumstances, the person who is now the paid clinical program leader ended up being the department chair. That's what I mean when you see these structures start to collapse into each other, right? The next thing that happened is more and more our regional vice presidents and hospital operators would come to the clinical program leader with problems that they encountered in their region and get them to solve them. So, you know, all of a sudden it's the clinical program leaders who are handling most of the supply chain stuff, all the coordination for supply chain, this kind of stuff. And the reason is they had the fundamental knowledge. And they were in routine contact with the clinical practices. And so what's happened is that these medical directors, for many of them, their role has fundamentally expanded. Mostly at the regional level, not at our level here corporately, but at a regional level to the point where there's discussion, do we need to expand their job description, expand the amount of paid time they have to cover the need? You see? So that's the kind of things that you see start coming together on these things. Does that kind of make sense? And my prediction is if we just let it run for a while, it's going to merge into a single structure eventually. We're doing some other things. I'll show it to you later. Just this year, well, you saw the financial analysis. We think that Medicare is trying to figure out every way in the world not to pay us in response to their budgets, right? Which is understandable. We don't know what it's going to look like in the long term, except that our payment is going to get hit hard every time we turn around, we think. And the only thing we can come up with to survive in that emerging new market is to be able to manage our cost structure. And we think that perhaps 80% of our opportunity to manage cost structure comes at a clinical decision-making level on the medical staff side of the line, nursing side of the line, not on the administrative side, right? So we're building up this structure. Then Reinertsen comes in and says, well, you've got a culture problem. He says your line administrators still believe that most of their success depends upon their ability to manage a budget. You see, Dave Burton and I actually debated this way back in 1999. And Dave wanted to wait. He wanted to wait until our IT was better, which I thought was probably foolishness knowing how slow IT can be. Well, I got tired of waiting. And when Dave retired, I just pulled the trigger on it. We know that we're going to have to manage our cost structure. All right? There's no question about it. We know that in the short haul it will hurt us financially because we'll create windfall savings for insurers. But we think we can recover a lot of that money back through contracting. But we don't know how we'll be paid in 5 years and 10 years, but we know it will be different from how we're paid today. We're absolutely sure of that. And that cost structure, we think, is the name of the game strategically, right? Well, what I got coming down from administration, our current EVP, Joe Horton, Joe says, Brent, I've got to have something that will allow me to manage clinical cost structure, which was music to my ears, actually. So I went back and started to reformat our finance data. I've done it so far just for pregnancy, labor and delivery, and ischemic heart disease, the two biggest ones, right? Where I reformat a set of financial reports along the lines of clinical decision-making that shows a tight linkage between the clinical decisions you make and what it does to your finances. So for pregnancy, labor, and delivery, it basically breaks out decisions around things like elective induction and C-sections and a whole series of other decisions that you make, all right, that we know that we can change through good clinical management. And then what we did is just showed the true cost broken out across time, our actual revenues in total and by payer. By payer is going to turn out to be really important on this thing because different payers pay us in different ways. Then we show our net operating income, our contribution to margin in each of these things, right? We have the initial set of reports up and running now. Well, we're just getting them to full automation. And Joe Horton, our EVP, says he's going to start sending them out to our regional vice presidents. We're going to set a date certain. Joe says he wants to give them a year to get used to them. I think we ought to do it in 6 months. I think I've got pretty good support within the line management of the system to do it in 6 months, at which point we'll start to hold our regional vice presidents accountable to clinical decision-making that directly drives cost structure. All right?
Individual hospital CEO report to the regional vice president?
Yes, and the regional vice president reports right up to Joe Horton. All right? But what it does is it gives me a clinical system that I can budget against. So these guys like to run budgets. Okay, we're going to start to budget your elective C-section rate. When I first told Joe about this and showed him how it would work, he said, yeah, Brent, but he says, but I can't just give them the responsibility. I have to give them the tools by which they could actually manage it. And I said, well, geez, Joe, what do you think we've been building for the last 10 years in the clinical program management structure? That's why those guys are there. I've taken it out to the clinical program folks, and what it does is just make them much more central in line management. So it gives those clinical decision makers a much, much tighter role in terms of how this system is managed. You see? And frankly, we think that's where a big chunk of our future lies, is along those lines.
And then the clinical data repository is all coming off here, the site?
Yeah.
The site don't have any?
Nope, we run it all off a big central EDW. All right. So, and it's all done in the same data structure so that you can learn from each other. So what you're seeing, if you think about this, there's nothing really too surprising here. It's just a management structure applied to our core work of clinical care delivery. Oh, it has this major secondary effect. You end up with the data systems that your ability to do research just skyrockets. You're building a learning system around clinical efforts, right? The interesting thing is it requires at least as much change from administration as it does from the clinicians, because you're really starting to give clinicians a very significant leadership role in clinical management. But with a shared set of goals with the facilities side, right, to manage the whole enterprise together.
I would argue that there are many clinicians that would say you're being held back from innovation by...
Yeah. You'd say they're being held back from innovation, you say, Chris, in the sense that they're not getting the support they need to drive this, right? Oh, I got to agree with you. And I think I know the cause, Chris, of why they're not getting the support. I think that there's this, it's culture change, right? And I think there's still this persistent belief that that if you manage the budgets, our traditional financials, that's how you succeed from the administrative side. So you'll come up and say, we really need to do this, and say, well, I can't budget for that. The budget won't support that, right? And when you look at it closely, you can kind of see what they're saying from the context in which they're trapped. Well, my simple solution was, let's give them a better context that more accurately reflects that clinical reality. You see? So I just saw a real report. The question was, if we got our elective inductions just right, what will it have to do on emergency C-section rates within the system? Well, it turns out that against best theoretic practice, if we got emergency C-sections down, we could be lower than we are right now. We're already probably the lowest in the country, or very close to it in the country. But we could get down further. The trick is our C-section rate will drop. The hospital administrators make more margin every time a C-section is done than they do for just a normal birth. All right? So we estimated that if they got to the perfect level, the system would lose about $1.6 million in margin. Not total revenues, but just margin, right? So $1.6 million budget hit. You see? Oh, the trouble is, it's just for our own health plan, which is about 25-30% of all the deliveries we do. The health plan will save $2.6 million in clinical expense. And if you multiply it through for all of the people that we supply these services to, it was something like $8 million. So they're getting $1.6 million by tolerating a higher emergency C-section rate driven by elective induction rates, all right? And it means that, yeah, they make 1.6 million and the system as a whole loses 8. Now, the difference between those two numbers is called arbitrage. And we think that if we had the management system in place, and we think putting this financial in there so that you can link them up tightly, and then starting to hold those people accountable to a budget. They will like budgets. Well, we can do budgets. It's just that the budgets, Chris, will have to do with clinical decision making. We think that'll change their decision making. Now, it'll take a while to get it in place. But we think that's the next step, and then what it will do is even more tightly align the shared goals and motivations of our administrative and clinical side, and I'd like to see them come to one so we don't hear this anymore. So it's the same role you're in. What you really control for your system is context, the context within which people see their world and work, right? And it's a little bit of a higher order job. How do you build the right context for the people who work there so that they can make better decisions? You see, the funny thing is, Chris, just to use the example you brought up, when I go talk to the administrators, I can understand exactly where they're coming from, given the way they see the world. I just have to change their perception of the world a little bit so that it lines up a little bit better and then hopefully addresses those legitimate issues that you're raising. Now, I frankly think of it as make it easier for them to do it right. I don't have to make them smarter. I don't have to make them more dedicated. It's not a matter of motivating them. It's just getting the context right so that the decisions match up to our patient needs better. You see? And so that's what we're trying to do. Does this kind of make sense then for the organizational structure standpoint? You okay with that? Any other comments or questions? If you think about something overnight, come back to me. So Kim, makes sense? I bet you don't get so heavily into the organizational stuff, or maybe you do.
Oh, no, the big question I have is pretty specific to me, so I want to know how primary children fits into the picture and
Yeah.
what the structure is.
Yeah.
That's
Yeah. Primary children's is fairly unique. Actually, Shrina, does it make sense in terms of your background? So, Dana, anything to add? All right. Well, have you had enough for one day? Tomorrow, I think it gets a lot better, mostly because you don't necessarily have to listen to me. So if you look at the rest of the work, tomorrow morning, we have Dr. Milt Weinstein coming in to speak to you. There's this field of math applied to medicine called decision analysis. Milt Weinstein's name is on the old original book. He's an old friend. When I showed up as a fellow at Harvard in biostatistics and working with the Eastern Cooperative Oncology Group, they let me attend any course I wanted, just show up and attend. And I attended, I think, the second or third year it was offered, Milt's course on medical decision making, and boy, was it insightful. It was just plain fun. He's since published a series of books on the topic. I think he's regarded as the international expert on decision making. All right, at this point. Well, thought it would be nice for Milt to come in and describe how to think about it, what he does. Now, you need to know that Milt's kind of a typical academic. He's probably not the most glowing presenter in the world, but you need to pay close attention because there's some real substance in behind it. He's going to try to show you the nuts and bolts of how it works, right? Now, after Milt gets done, on Wednesday morning, Sandy Schwartz will be here. Sandy is a physician at the Hospital of the University of Pennsylvania. He's also a professor at the Wharton School of Business, all right? And Sandy's going to take what Milt starts with and turn it into cost-effectiveness analysis. Turns out that the theoretic basis for cost-effectiveness analysis is decision analysis. There'll be a little bit of overlap between them, but really a different presentation style, and usually when we get them in this order, it works really, really well between the two of them, okay? You might want to help Milt a little bit. He's going to give you some good clinical examples. He's pretty good at getting it clinically focused to show you what he's really trying to do, but you know, ask him good questions to help him develop these ideas. Tomorrow afternoon, I've invited Scott Lloyd and Christy North to come in. They're going to talk about the 8 quality planning tools and describe them in context. So this is strategic planning. The first 4 of the quality planning tools, brainstorming, affinity diagramming, interrelationship diagraphs are the big one, the really cool one, right? And then gap analysis should be part of your general quality improvement toolbox. You can use them in many different settings. And then they'll go through the last 4 tools are kind of technical strategic planning tools, building on some of the stuff we've already started to talk about with key process analysis, all right? And they're going to take you through the theory and then a hands-on experience of it that other classes have found to be quite valuable. On Wednesday afternoon, Dr. Frank Drews is going to be here. Frank is a educational psychologist who specializes in human factors. So this is part of the patient safety curriculum. And he's going to give you a very good introduction to human factors thinking, all right, in terms of how you design work processes so people don't screw up, with some wonderful clinical examples and into the theory of how you approach them. It's a real hard thing. He's not going to be able to make you human factors engineers in 4 hours, right? But I've asked these guys to give you enough background that as a leader in the system, you can see what's going on. So that's Frank. Oh, the other thing you need to know about Frank, we've actually expanded his time out. The reason for that, he's the guy who did the initial research linking cell phone use to automobile accidents. So you hear all this stuff about allowing people to talk on cell phones while they drive. He was part of that research team, and what happened, every dang time he came, this would kind of get mentioned, and the next thing you know, the class would be all over him asking questions about it, and so we just gave up and stuck it in because it's fascinating. So you're going to discover that talking on a cell phone, and it'll list the reasons why, is a little bit more dangerous than driving drunk. All right? Ask him about texting. I don't know if they directly measure it, but texting is substantially more dangerous. So, but he'll describe that to you, and it's just plain fun. On Thursday morning, we have Joe Duhigg coming in. Joe Duhigg's probably the finest Lean Six Sigma guy I've ever met. He's led a series of very successful Lean implementations in healthcare, in labs and the like, right? And now he's senior vice president for the Duran Institute, and just plain a great guy in his own special weird little way. But I can't imagine anybody better to spend a day with you, or most of a day, talking about Lean Six Sigma and just the additional things you need to know around that. And then finally, on Friday morning, I really want you to listen to Alan Morris for 2 reasons. He's the guy who invented shared baselines. So historically, you ought to, just because it's becoming such a central part of clinical practice these days, to go back to the old original roots, to the source of it. But the second reason is I want you to see a rigorous method for generating them. Now, he's going to be way over the top compared to the way that I do it. All right? But it's good to see the full rigorous application of it, because there'll be days when you'll really like and rely upon that stuff. So that's the week. Kind of a full, fun, drink from a fire hose week, I suspect. So buckle your seatbelts, guys. It's going to be a pretty darn full week this week. And frankly, it'll just build as we go along. The funny thing is a month from now, that week will be even better. Wait and see. And we'll just continue to ramp on up on it. Fair enough? Well, thanks for sticking with me. See you tomorrow at 8? Well, wait a minute. Some of you have the Excel homework stuff at 7:15, if you choose to come to that 7.